We're now going to talk about the acute abdomen. All the vignettes that I will eventually read are vignettes of patients who have severe abdominal pain. And here's how we're going to do it. First, I'm going to give you a description of how we can recognize when we read a question what type of process is taking place on a patient who has acute abdominal pain. I'll do that just by chatting with you and you're looking at my face and we talk about it. I'll then read the vignettes, and then at the end I'm going to repeat everything by means of images on the screen and words on the screen. So we're going to do this twice. Okay, there are 4 types of processes that can give you an acute abdomen. The first one would be a perforation of the viscus. When that happens, the pain has sudden onset, is very severe, constant, generalized all over the abdomen. The patient doesn't want to move, and the physical exam is very impressive all over the abdomen. That's a perforation. Second type of problem that could give you an acute abdomen is an obstruction of the ureter, an obstruction of a cystic duct. There the pain also has sudden onset, but is colicky rather than constant. And it's localized rather than all over. It's in the area of that organ with often specific radiations that we can recognize. And the physical findings on a patient who has an obstructive process, they are very minimal as far as the abdomen in that patient is thrashing around, moving in the stretcher, trying to find a position of comfort. He doesn't find it, but he's trying. The third type of process that could give you an acute abdomen is an inflammatory process, that enormous collection of diseases that end with itis. Acute appendicitis, acute pancreatitis, acute diverticulitis, acute cholecystitis. There, typically, the pain has a gradual onset, a few hours before it reaches maximum intensity. Once it reaches maximum intensity, it is a constant pain, but it's not all over. It's in the area where the inflamed organ is, often with radiations that are typical for that organ. There will be impressive physical findings, but not all over the abdomen, only in that area of the abdomen where the inflamed organ is. And except for pancreatitis, in all of the other inflammatory processes, there will be fever and leukocytosis. And finally, the fourth process that can give you an acute abdomen is an ischemic process. I cannot give you a pattern of pain there because it can vary a great deal from one patient to another, but I can remind you that in an ischemic process that gives rise to abdominal pain, you also will see blood in the lumen of the GI tract. Typically, patients who bleed do not have pain. Typically, patients that have pain do not have blood. If the two are happening at the same time, we think of an ischemic process. Okay? With that little background, let's begin now to review vignettes, and eventually I'm going to repeat all these by means of decision trees and words on the screen. So I'm going to read vignette 35. A 59-year-old man arrives in the ER at 2 a.m., accompanied by his wife, who is wearing curlers on her hair and a robe over her nightgown. You know this was a pain of sudden onset and very severe. Otherwise, the lady would have had plenty of time to look her best. Okay? He has abdominal pain that began suddenly about 1 hour ago. It's now generalized, constant, extremely severe. He lies motionless on the stretcher, is diaphoretic, has shallow, rapid breathing. His abdomen is rigid, very tender to deep palpation, has guarding and rebound tenderness in all quadrants. This is a perforation. It's got all the characteristics of a perforation. I cannot tell you if it is a perforated ulcer, a perforated diverticulum, or a chicken bone the patient ate and punched a hole in the bowel. I don't know, but I know he's got a perforation. And I know also that he needs an emergency exploratory laparotomy. Now, we don't like to do an emergency laparotomy for something that might masquerade as an acute abdomen. So we always do an EKG and cardiac enzymes. We don't want to be operating for an MI. We do either x-rays of the abdomen or nowadays a CT of the abdomen because we don't want to operate for a stone in the ureter. That would be the wrong thing to do. And we check an amylase or lipase because we don't operate for pancreatitis either. And we look on a chest X-ray or on the CT scan for lower lobe pneumonia, another little trap. But once we've ruled out those traps, what we do on a perforation is an exploratory laparotomy. Okay, let me move to the next. A 62-year-old man with cirrhosis of the liver and ascites presents with generalized abdominal pain that started 12 hours ago. He now has moderate tenderness over the entire abdomen with some guarding, equivocal rebound. He's got mild fever and leukocytosis. This is a trap. This sounds like an acute abdomen, but it's not. And your first tip, and I'm going to repeat this is a patient with ascites. When you have a question on the exam that sounds like an acute abdomen, but the patient has ascites, watch out. It may be primary bacterial peritonitis. This would be a child with nephrosis and ascites or an adult with cirrhosis and ascites, but the ascites is there. And once you're alerted by the presence of the ascites, you read it again and you're going to encounter what I call apologetic terms. We're describing all the findings in a way that says, look, this is not a real thing. Let me read this one again. He presents with generalized abdominal pain. He has now moderate tenderness, some guarding, equivocal rebound, mild fever. See what I mean about these apologetic terms? This whole constellation adds up to primary bacterial peritonitis. The answer is not an exploratory lab. The answer is you tap the ascitic fluid, send it to the lab for gram stain and cultures. You'll identify a single bug, single bacteria, and you treat it with antibiotics. Well, let's go back now to the more typical acute abdomen pictures. Vignette 37. A 43-year-old man develops excruciating abdominal pain at 8:18 p.m. Now you're going to laugh at me. This was not 8:17, this was not 8:19, it was 8:18. But it's my way to alert you, sudden onset of the pain. When seen in the ER at 8:50, he has a rigid abdomen, lies motionless on the examining table, has no bowel sounds, obviously in great pain, which he describes as constant. An X-ray show free air on the diaphragm. If you had any doubt, you now know it's a perforation. And remember, after you rule out other things, you do exploratory lab. A perforation is here, you need an exploratory lab. Vignette number 38. A 44-year-old alcoholic man presents with severe epigastric pain. Let me stop right here. When the patient is an alcoholic, you start thinking right away pancreatitis. Let's see if it fits. Presents with severe epigastric pain that began shortly after a heavy bout of alcoholic intake, reached maximum intensity over a period of 2 hours, an inflammatory process. The pain is constant, epigastric, radiates straight through to the back, an inflammatory process. It's accompanied by nausea, vomiting, and retching. He had a similar episode 2 years ago for which he required hospitalization. This is indeed acute pancreatitis. You check amylase or lipase. If needed, you might do a CT. You typically don't need it for diagnosis. And then you put the pancreas at rest. And we're going to talk more about these on the chapter devoted to the pancreas. Let's move on. Vignette number 39. A 43-year-old obese mother of 6 children has severe right upper quadrant abdominal pain. I have a diagnosis already. Remember the mnemonic from medical school, all the F's? The fat female in her 40s who has, as I often say, 55 children, who's had a bunch of pregnancies, has right upper quadrant pain. That's biliary tract disease. Let's keep reading. The pain was colicky at first, radiated to the right shoulder, around towards the back, was accompanied by nausea and vomiting. For the past 2 hours, the pain has been constant. She has tenderness to deep palpation, muscle guarding, rebound in the right upper quadrant. The temperature is 101. White count is 16,000. I don't even need to read the rest. You know already this is an inflammatory process. And given who she is, probably an inflammatory process of the gallbladder. This is probably acute cholecystitis. We'll have more details when we talk about the gallbladder. Let me though say it right now so that we repeat it eventually and learn it twice. You start with a sonogram. Typically that gives you the diagnosis. If it's equivocal, you do an AIDA scan. And then you typically begin with medical management to cool down the case. Let's move to the next. Vignette 40. 52-year-old man has right flank colicky pain of sudden onset that radiates to the inner thigh and scrotum. There is microscopic hematuria. That's a urethral colic. You know it is an obstruction because it's colicky pain of sudden onset. It has a specific location. It has specific radiation. And when it is in the flank and goes to the scrotum or the labia, if there is a blood in the urine, it's a stone in the ureter. We'll have a chapter dealing with this, but I might anticipate that and say that what you do next is a CT scan. Patient number 41, a 59-year-old woman, has a history of 3 prior episodes of left lower quadrant abdominal pain, for which she was briefly hospitalized and treated with antibiotics. She began to feel discomfort 12 hours ago. Now she has constant left lower quadrant pain, tenderness, a vaguely palpable mass, fever, leukocytosis, and inflammatory process. You know, once we've decided a patient has an inflammatory process, how do we know what organ is inflamed? We think of 2 things. What is the anatomic location of the findings, the pain and the physical findings, because that's an organ that's there, and also which is the disease that is most common. So if we had a presentation of an inflammatory process in the right upper quadrant, you think of the organs that live there, the biliary tract, the gallbladder, the duodenum, the adrenal gland, but you don't begin your list with the adrenal gland because you know that acute inflammation of the adrenal gland is not a common thing, whereas acute inflammation of the gallbladder is very common. So you put those 2 things together. Well, this is left lower quadrant. What do we have in the left lower quadrant anatomically? Both men and women have a sigmoid colon. Women also have an ovary and a tube. This could be acute salpingitis or a twisted ovarian cyst or acute diverticulitis. Now I'm going to tell you a very dirty trick here. This is not something that I'm proud of because this will not make you a better physician, but it will help you with the exam. I know from reading this that this is not in the ovary or the tube, because this patient is, quote, I'm going to read, a 59-year-old woman, etc. When an OBGYN question appears on the exam, they always tell you how many pregnancies and how many deliveries that patient has had. So when you read a 59-year-old gravida 5 para 4 lady, you know the pathology is GYN. But when you don't find how many pregnancies and deliveries, it's probably not. And in fact, this is a pretty good presentation for acute diverticulitis, for which you're going to do a CT scan as your first diagnostic step. Let me move to vignette 42. An 82-year-old man, let me stop right there. Acute abdomen in the very old. You think immediately of 2 possibilities, a sigmoid volvulus or mesenteric ischemia. Let's keep reading. 82-year-old man develops severe abdominal distension, nausea, vomiting, and colicky abdominal pain. He has not passed any gas or stool for the past 12 hours. He has a tympanitic abdomen with hyperactive bowel sounds. X-ray shows distended loops of small and large bowel, and a very large gas shadow that is located in the right upper quadrant and tapers towards the left lower quadrant with the shape of a parrot's beak. This is a whole description of a volvulus of the sigmoid. We take this man to the endoscopy suite. When we do the proctosigmoidoscopic exam, the instrument on the inside of the lumen will untwist the sigmoid, let all that air out of there. We leave then a long rectal tube, and if this is a recurrent problem, we do a resection of the sigmoid. Let's move to vignette 43. A 79-year-old man with atrial fibrillation develops an acute abdomen. I have the diagnosis already. Atrial fib, acute abdomen. It's mesenteric ischemia. You have a clot that left the atrial appendage and went down and got lodged in the superior mesenteric artery. Let's keep reading. He has a silent abdomen with diffuse tenderness and mild rebound. there is a trace of blood in the rectal exam. Remember what we said just a couple of minutes ago? Pain and blood in the lumen at the same time? That means an ischemic process. Here you have it. He has acidosis, looks quite sick. X-ray showed distended small bowel and distended colon up to the middle of a transverse colon, the territory that is fed by the superior mesenteric artery. This is indeed mesenteric ischemia, unfortunately, very late. He already has dead bowel. He has acidosis, he already has dead bowel. We're going to do an exploratory lab, find dead bowel. I might add, there is an ongoing push, an ongoing effort made to diagnose this very early. The young, aggressive, well-trained vascular surgeons are preaching to the rest of the physicians, saying, look guys, when an old man with atrial fib is on the phone and says, I have abdominal pain, don't wait around for a day or two. He will have dead bowel by then. Call us right away, because that's bound to be mesenteric ischemia. We'll do an arteriogram, we'll show that the SMA is occluded, and we will do a vascular procedure to open it up. So you pay attention to the timetable in your exam question. If the patient that has atrial fib and is old develops an acute abdomen and that happened just an hour ago, your answer is do arteriogram and have a vascular consultation. Whereas if it happened 2 days ago and he already has acidosis, well, he's got dead bowel already. All right, let's repeat all this. We're going to cut away from my face. We're going to go to words on the screen. This is all territory we already covered, but let's cover it again. So we have an acute abdomen. Let's ask ourselves, what would be the hints we get by knowing who is the patient? If it is a patient with ascites, we suspect primary peritonitis. We look in the description for what I mention as apologetic terms. This is not quite an acute abdomen. You tap the ascites, you do gram stain and cultures, and you treat with antibiotics. Let's move to the next. Who is the patient? An alcoholic. You think immediately of pancreatitis. You check the amylase or the lipase, you put the pancreas at rest. Here is a CT scan of the abdomen showing acute pancreatitis. You would do these only if the amylase and lipase are equivocal and you cannot otherwise make the diagnosis. Let's have another. Who is a patient? A fat female in her 40s, and please bear with my exaggeration here with 55 children. You know nobody has 55 children, but when you have this presentation, fat female in her 40s, many pregnancies, you immediately think biliary tract disease. You always start that workup with a sonogram. Here is a picture of gallstones on a CT scan or in a plain film, but let me emphasize that you do not begin with either of these two, you begin with a sonogram. Let's have one more. Who's the patient with acute abdomen? If it is a very old patient, you think of sigmoid volvulus or mesenteric ischemia. What if it is a patient with atrial fib? Then you know it is mesenteric ischemia. Now let's review the mode of presentation. This is what we did just before we had the first vignette. Let's do it one more time. If the pain has sudden onset, it's generalized and constant, the patient doesn't want to move. There are impressive findings all over the abdomen. That's a perforated viscus. You rule out the traps with the EKG, the chest X-ray, the amylase or lipase, and an abdominal X-ray or CT scan, just to be sure you're not going to be operating for something that is in fact not an acute abdomen, and then you do an exploratory laparotomy. Here is a picture to remind you how free air looks like under the diaphragm. This patient clearly has a perforated viscus. Okay, let's have another mode of presentation. If the pain is of sudden onset, but it is localized with specific radiation, it is colicky, the patient is thrashing around, there are minimal physical findings, that's an obstruction. The obstruction that we're talking about is typically either the ureter or the biliary tract. However, in reviewing these pictures showing obstruction of the bowel, I'm going to show them to you, although you do not think with this presentation of bowel obstruction. But here is a picture of a small bowel obstruction and a picture, for contrast, of large bowel obstruction. Let's continue then with the decision tree. If we think the patient is obstructed, then we ask ourselves, where is the pain, in order to decide what organ is obstructed. If it is in the right upper quadrant, radiating to the right shoulder, around to the back, it's from the biliary tract, and you do a sonogram. But if it is in the flank, radiating to the inner thigh, the labia or the scrotum, it is in the ureter, you do a CT scan. Let's continue with the mode of presentation. If the pain is constant, localized with specific radiations, there are impressive physical findings, but only in the affected area. If there is fever and leukocytosis, you know that would not be present in pancreatitis, but otherwise you know this is an inflammatory process. Now your next question, of course, is what organ is inflamed? And to make that decision, you think of anatomic location, which organ is where, and what is the most common disease. And you put those two together. Let's remember again something that we have mentioned. If you have both in the mode of presentation, both pain and blood within the lumen of the GI tract, that combination, pain and blood in the lumen, that is an ischemic process. And that's the end of this particular sequence of slides.